My name is Lindsay Coates, and I am Vice President of Strategic Operations for the Sierra Sacramento Valley Medical Society. And on behalf of SSVMS, I would like to welcome you all to tonight's CME presentation, Continual Growth, Self-Reflection as a Tool for Improving Patient Health Outcomes. So our speaker tonight is Dr. Elizabeth Morrison, and she is the CEO and Principal Consultant of EM Consulting. And the foundation of all of Elizabeth's work has really focused on centralizing the human connection in healthcare. And that's through the development of integrated care systems, implementing trauma-informed care practices, and elevating the vital importance of skillful, empathetic communication, both in person and, of course, virtually. So Elizabeth has a PhD in social psychology. She is a licensed clinical social worker and has a master's in addiction counseling. Now, I've had the pleasure of working with Elizabeth for the last 8 months or so on increasing access to medication-assisted treatment for pregnant patients in Sacramento County. And she will be presenting more on this topic in a continuation of the one tonight on Wednesday, December 7th at Zinfandel Grill in Fair Oaks. If you've not already registered for this free CME event, I'll actually throw the link here in the chat when I'm done talking. So just a bit of housekeeping before I turn it over to Elizabeth. Please submit your questions in either the chat or the Q&A function. I believe Elizabeth will answer them throughout and take periodic breaks to go through whatever questions you may have. And we'll also go through them at the end of the presentation. So tonight's presentation is worth 1 CME credit, and later this week you will receive an email with a survey link. After you filled out the survey, your CME certificate will be emailed to you. Now, in order to verify that you are in attendance, please make sure you list your full name in your Zoom profile so that I can mark you down as here. So Elizabeth, I will turn it over to you. The floor is yours.
Thank you. Thank you, Lindsay, for that introduction. And just big thank you to SSVMS for sponsoring this workshop and inviting me here. I do want to just put a plug in. Lindsay and I were just chatting before we opened up that next week I'll be in person up in Sacramento at the restaurant and would love to see you all. One of the things that I was saying that we get to do in person a little more is laugh together. It's a little bit harder on virtual webinars. We don't seem to get like quite as much laughter. And this is a Zoom webinar, which means I can't actually see you. You can see me if you're not driving or just listening, you can see me, but I can't see you. And so it becomes a little more difficult to feel like we're sort of together. And so I really want to double down on what Lindsay just said, which is I would love to hear from you via chat. Please chat in as much as you want. I will always stop and pick it up. And if I miss it, Lindsay will stop and pick it up so that we can talk about it if it's a question or if it's a comment or you want to add something. So please, please feel free to do that. I also am realizing, I tinkered with the title of this presentation a couple different times. And I think one of the things that I want to say is that there is something that sounds a little bit like be a better person here. And I think when we talk about stigma, which is what we're going to talk about today, sometimes there can be a sense of like, oh, like, we should all be doing better somehow. We should all be stigma-free or, spiritual beings with like no judgments. And I think what I want to just start out by saying is you all rock. I know that like, even if I don't know you, I know you're awesome. I know you're already doing good work. I know we're all doing our best. I know you're providing amazing care to patients. And I am certainly not, I don't consider myself an expert on empathy or a person who doesn't have any stigma or judgments because I'm human. And I'm just in constant practice, just like all of you. So I see myself more as a shoulder-to-shoulder practitioner. And in fact, sometimes because we're going to talk a lot about empathy today, sometimes I like to just say at the beginning, in case like I in any way sound like I'm an expert in empathic communication as opposed to like a student and a practicer, you would just have to talk to my kids because it's not uncommon for them to go, oh my gosh, like you teach communication skills. Did you hear what you just said to me? So definitely a fellow practitioner. All right. Well, of course, like I said, big thank you to SSVMS. The Sacramento Opioid Coalition is partnered in this work that we're doing to be able to present this to you today. And this is all, of course, for the very, very worthy and important goal of expanding access and quality of treatment for pregnant and parenting women who have an opioid use disorder. Today, many of the things we're going to talk about apply to all different types of stigma and treatment and patient interactions. But that is really what this work is focusing on. So those are a lot of the examples that we'll use today. I just the kind of CME disclosure that I've got nothing to disclose and nothing from anybody. Let me just ask you all this, if you can type in the answer to this. This is just, it might even seem like a little bit of a trick question. What has the biggest impact on SUD treatment outcomes? And this is just the evidence base. When we look across all substance use disorder treatment, whether it's medication-assisted treatment in primary care, or whether it's specialty residential or intensive outpatient, what do you think has the biggest outcomes, the biggest impact on outcomes? I would love to, if anybody just wants to like type in, I don't know, A, B, or C. Yeah, Jen thinks C. Anybody else? Anybody think otherwise? Well, Jen, it's a C, it's C. So I love that you knew that and sort of chatted that in really quickly. Many people feel like it's mandated versus voluntary status. It's really common for us to think that people need to want to change in order to get better when they start treatment. And I ran treatment centers for a number of years. And for anybody who's worked in addiction treatment, and that might be some of you, you know that when a person comes in and says, my probation officer is making me be here and I do not want to be here and I do not have a problem. And you have another person who comes in and says, oh my God, I have such a terrible problem. I'm so glad you had a bed for me. Sign me up. I need help. That initial indication does not tell you who will get better. So super interesting that it's not a driver of outcomes. And the second one, of course, readiness to change does matter, right? It does matter what stage people come in. The person who was involuntary and doesn't think they have a problem are coming in where they don't even think they have a problem. The person who's voluntary thinks they do. But that all by itself doesn't predict changes either. It's C. It's the therapeutic alliance with our patient. It's the ability for the treatment team, for the physician in terms of medication-assisted treatment and your team, if we're talking about treatment centers or outpatient, the counselors, it's their ability to develop an empathic, trusting therapeutic alliance that actually determines outcomes more than anything else. And the reason, of course, and this is the basis of everything we're going to talk about today, is that empathy is healing. Empathy is a treatment all by itself. It's an evidence-based treatment all by itself. And when used with other treatments, it makes other treatments more effective. And when I'm talking about empathy, I'm talking about it in the broadest sense. So there can be, sometimes there's sort of academic distinctions about sympathy versus empathy and affective versus cognitive. And I'm a real nerd about this and about the research around this. And my own doctoral research was on this. So I can get really nerdy about it too. For our purposes though, when I say empathy is healing, I'm really talking about the broadest definition of empathy. You know, when we talk about trauma-informed care, when we talk about kindness or having goodwill towards someone, respect, understanding, often when patients say, I felt really listened to, they're talking about empathy. They feel very cared about. So listening, rapport, perspective taking. In my field, we call it the therapeutic alliance. So very broad definition of empathy. Now, it might be that those of you who signed in for this workshop today already have an interest in it and may already be deep into this research. I'm sharing this because I think it's so fascinating. And even if you didn't know there was a body of research around empathy as a treatment in medical sciences, you probably, once you hear it, you probably are thinking, well, yeah, that makes sense. And I just want to share at the end, I'll share a link to my website where I have a very extensive bibliography and all of this research that you can do a quick search on, and it's divided up by different subjects within empathy. So if you're want to take a deep dive, it's annotated, so very easy to skim through. But I'll just share a few pieces of it, which is the research on empathy in the medical sciences data is absolutely compelling. It shows that when patients come in to see us and they feel empathy from their treatment team, because although much of the research is on physicians, there's an increasing amount of research on the team, on nurses, case managers, behavioral health providers. My own doctoral research was on receptionists and their empathy and the impact on healthcare outcomes. So we know it's really the whole team. Empathy is kind of equal opportunity. But when patients come in and feel empathy from the healthcare team, we know that people with COPD have better healthcare outcomes. We know that people with diabetes have lower A1Cs. We know people with wounds heal faster with less infection. We know people with a common cold, when they are met with empathy from the healthcare team, have less severe symptoms for shorter duration. And we can go on and on and on. We can talk about obesity and how people are more apt to lose weight when they're met with empathy from their healthcare team. We know that in mental health, that people have lower scores on depression and anxiety screenings just from skillful empathy from their provider. In substance use disorders, which of course is what we're focused on, I would say that the research is most compelling, and it's the longest term. So we have about 40 years of research in substance use disorder treatment that shows that empathy is correlated to better healthcare outcomes. And it's really so that there's such a fine point on it that they can actually drill down on very specific ways of communicating empathy and really specific healthcare outcomes like treatment retention and days abstinent. And then also, most other behavior changes that you can think of, there's research that shows that empathy has an impact on them as well. So intimate partner violence outcomes, positive parenting strategies, vaccine hesitancy. There's just a whole mountain of other behavior changes that are shown to have a good correlation with empathy. So super, super fascinating. The opposite of empathy is judgment. And we could say judgment, bias, and stigma are really all the same thing. They're all a cluster of negative attitudes and beliefs about a group of people or about particular conditions that people have. So we all know what it feels like when we've all probably been judged by someone in our family or by our in-laws. We also, of course, know what it feels like when we're judging others. And so sometimes I use the word judgment just to make stigma a little bit easier to wrap our minds around, because I think otherwise when we talk about stigma, there's this tendency to think that other people might have stigma around addictive disorders, but we don't. And it's really just judgments, and all of us have those. And if you were raised in the US, you were probably raised with a bunch of stigma and judgments about people with addictive disorders, or maybe even particular drugs or alcohol and other drugs, or particular groups of people, or we might have been brought up with certain ideas or judgments about whether shooting drugs was sort of worse than smoking drugs, or whether alcohol was better than other drugs, right? There's all kinds of conditioning that we get that despite all of our schooling, we tend to harbor these ideas about addiction and about people who have addiction. And because it's the opposite of empathy, I like to think about empathy and judgment, or empathy and stigma, as kind of like a teeter-totter. where the more empathy that we're feeling, the less judgment and stigma we have for somebody. And the higher our stigma and judgment is, the lower our empathy is. So, like I said, we're all human. So we're always kind of in this little teeter-totter, probably with people in our lives too, of course, certainly with our patients. And the reason I like to place it kind of a visual, like a teeter-totter, is because there are things we can do to like, once we realize that we're in judgment or we're in stigma, once we notice that, there's actually things we can do to sort of bring that down and bring empathy up. Sometimes I call these empathy hacks, and we're going to talk about them before we end the workshop today. Just like with empathy, I'm going to use the term stigma, judgment, and bias interchangeably, and we could use any one of these words as well. Sometimes we use the word discrimination, discounting, condemnation, stereotyping is really the same sort of process. So it's in the most general way. So just as there's a mountain of research on the impact of empathy on health outcomes, there is also the equivalent opposite research that is just as compelling, but also deeply, deeply sad, because it's about us as professionals. It's about my field in mental health. It's about nurses. It's about physicians. It's about nurse practitioners. It's about case managers. It's about those of us who work in healthcare. And just as an example, when I say the opposite is also true, there's research that shows that when patients who have diabetes are met with what feels to them like judgment from us when they come in for care, that they have higher A1Cs than people who are met with empathy. So the exact opposite of the empathy research. There's very compelling research that shows that when people have obesity and they come in and they're met with judgment, that people gain weight when they're met with judgment in our clinics or in our practices. There's the equivalent research for COPD. There's the equivalent research for wound care, that when people with wounds come in and are met with judgment or stigma, that their wounds take a longer time to heal and they're more apt to get infections. In mental health, there's a whole set of research separate that's exactly about the same thing, which is when people are met with judgment or stigma from the psychologist or from their behavioral health clinician, that their PHQ-9s start shooting up, that their GAD-7s shoot up, that people drop out of treatment. And in substance use disorders in particular, we see that when people are met, when they perceive judgment from us in their care, that people use more. People drop out of treatment, people have worse outcomes when they stay in treatment, and most importantly, and most specifically, people use more. And then the exact same is true in the other examples that I gave in vaccine hesitancy and IPV and parenting and all of the other behavior changes. So a couple things about biases or about judgments that I just want to share. The first one is the entire kind of philosophy or principle behind this workshop today is to normalize this. We all have them. We all have them. And so I never want to get in a conversation where we're sort of indicating that, people who have biases and judgments are somehow bad and people who don't have biases and judgments are somehow good. It's just it's not a helpful way to look at it, because we're just humans. And as helping professionals, as family members, as friends, every human has biases and judgments. So they might be really unconscious. We might not know we have them. We tend to think that other people are more biased than we are. And this comes from the research, so it may not be true as an individual. But when we look at the research, we see that typically people will say that they have less biases than other people have. And then the third thing that I think is super important is that often our biases, our judgments do not align with our conscious beliefs and values. So if I have very, very conscious, important, very strong beliefs and values around equality, around everyone being treated equally, around there being equal justice for people, regardless of skin color. That might be deeply, deeply important to me. It is deeply important to me. That doesn't mean that I wasn't raised in the US, where if we were raised in the US, especially if you're white, we were conditioned from the day we were born to think less of people who are brown and Black. And, we'll talk about sort of where all that stuff comes from, sometimes from our family systems, sometimes from movies, sometimes, so there's inconsistencies for many of us. As a therapist, I know that I'm unable to help people if I'm judging them. So I have a conscious value and belief around being able to be totally accepting and non-judgmental about anyone who's talking to me. But that oftentimes is inconsistent with what happens when someone comes into my office and sits down and talks about the fact that they're disciplining their kids by hitting their kids. That stirs up my judgments, and that becomes at odds with my conscious values and beliefs. And it's complicated because as humans, we have judgments, we have biases, and many of us are also on the other end of experiencing biases and judgments. We may be people of color, we may be women, we may be people who are disabled or who have a disabling condition. We may be people with chronic pain, which is right now one of the most highly stigmatized conditions in healthcare. We might have addictions ourselves. So we, maybe the recipient, maybe some of you have even been the recipient of judgment and bias around addictive disorders. I am a recovering person. So I've been in recovery from alcoholism for many decades now. And when I go see a new dentist or a new doctor, on the health history form, I do not fill out that I have a history of alcohol or other drug addiction. I always say no. And the reason I say no is I just don't know how it will be interpreted. And I'm always afraid that I'm going to end up with a dentist who wants to pull my wisdom teeth out and not give me pain medicine because they saw that they have a lot of judgments and misunderstandings about people who've had addiction. And they look at that mark on my health history form and they think, oh my God, no. So even me being decades in recovery and working in the field, I get really nervous about identifying that. So that is all to say we have biases and judgments, and most of us have been the recipient. So I wanted to ask you all about that. And I don't, it's 6:30 in the evening, so I don't know if I'm finding you eating dinner or doing your EHR notes. I don't know if some of you might be driving and you might not be able to do this. But for those of you who are, this is an anonymous way to just hear from you. So if you can capture this QR code with your phone, that's the easiest way to do it if you're sitting down, is just to pull up your phone and capture the QR code. It will take you to a page where you can type in what you've experienced. What kind of bias, negative bias have you experienced? Perhaps for the color of your skin, perhaps for your gender, perhaps for having a particular condition, perhaps for having a bigger body. Fat stigma is one of the most powerful and pervasive stigmas in our society. So if you're someone with a bigger body, my guess is you might have experienced some stigma about that. But I think I wanted us to just step out of the provider role for a minute and into just our human role and just ask what you've experienced. If you're not able to capture the QR code or you don't know how to do that on your phone, if you grab your phone and just go to menti.com, menti.com, it'll take you to a website where you enter this code that is on here, and it'll get you to the same place. So let me just go over there and see if that's possible, if any of you have been able to get on there, because I love to hear from people around this area. And I don't know if anybody has been able to get on. Oh, I saw. So someone chatted in that you have experienced bias or judgment around age and around gender. I'm really glad that you wrote age, because I think that ageism is very, very real. It's real in the job market. It's real every time you look at a bottle of shampoo and realize you can't read it. that the people who make that packaging are operating out of a bias of just not even thinking about older people. Wait, I'm so glad for the person who wrote that in. Thank you so much for doing that. We're focusing on substance use disorders here, but what I want to say is there is an entire mountain of research and work done around this really damaging part of our society where we have such stigma around people with bigger bodies. And just the fact that we know that people who have bigger bodies actually get worse when met with this kind of stigma. And then someone who wrote in that you've experienced stigma because of anxiety and depression. So mental health stigma, it is still real. We're going to talk a little bit about mental health stigma and addiction stigma in society right now, but it is still real. So thank you. Thank you for those of you who chatted that in. I appreciate you sort of stepping into that, like out of a provider role and kind of into a human role when you've been on the other end of this. So when we talk about like, yes, we're human. Yes, we all have judgments. Yes, we all have biases. Where does it come from? Where doesn't it come from? We're just humans, right? So it comes from our family. It comes from our culture. It comes from religion. It comes from schools. I'm 52. So I grew up, it might depend on the age that you are, but I grew up like I did not read one single thing in any history book that I read. I did not read one single thing about a queer person ever. And even though I like to think that I don't have judgments about that, and my daughter is queer, I've had decades of being conditioned that queer people were just not a normal part of society because I grew up not reading a single thing about them. Nobody ever identified any of the leaders that I read about or any of the authors. Because of my age, I grew up and I never had a single book assigned to read during all of my schooling that was written by a woman. Every single book I was assigned in K through 12 was written by a man. So that stuff goes pretty deep, right? That conditioning goes pretty deep about who we decide is important and who we decide is worth listening to or worth reading. Of course, social media, peers, movies. When it comes to addiction, when I look back at the movies, even in the 80s and the 90s, even if you look at the DVD covers of movies made in the 80s and the 90s, like there's a movie Colors, right? And it's always white police officers, and there's always brown and black people who are using drugs and in gangs. And there was like a whole genre of like an entire decade where that's all we ever saw is like white police officers, usually men, and black and brown people who were criminals. So that stuff goes pretty deep. I want to give you an example of a bias. I have a master's in addictions counseling. I'm a recovering person. I have worked running treatment centers for many years of my life. I have a deep commitment to total acceptance and non-judgment of the clients I work with. And yet I discovered these two biases that came from my dad. I'm from Alaska. That's my dad in Alaska. That's me, the little one, and that's my sister. My dad had terrible, severe alcoholism. He died of cirrhosis eventually. His alcoholism was already very bad when I was this age. But he was from Scotland. He immigrated from Scotland. He never finished high school. He was a laborer. He was a super hard worker, super proud, like all of you who are immigrant kids. Like I grew up thinking that like the most important thing you could be or do was a hard worker. Like that was it. And so I did not realize that I had judgments about people who didn't work until I came to work in primary care, and people showed up in my office with paperwork to be signed off of work, disability paperwork. And all of a sudden I started realizing that when people showed up with paperwork, I kind of stopped making eye contact with them. I kind of stopped listening to them very well. I would tell them no before I listened to their story. when they would tell me that they were disabled by anxiety. I'm a therapist, mind you. Like, I, of all people, should believe that people could be disabled by anxiety. I've seen it. But yet all of a sudden I realized when people were telling me this, that I wasn't asking more. I wasn't curious. And I finally started to unwind this with my colleagues and realizing that I have been so conditioned around hard work being the highest value, the most important thing, and that people who don't work are lazy, which is how I was raised with my immigrant dad, that it was making me provide poor care to people who were coming to me who were disabled by anxiety or depression. So I was able to unwind that. I'll tell you a second one that has to do with addictive disorders. I grew up knowing he was an alcoholic. We talked about it with my mom, like we all talked about it. So I knew that alcoholism was a disease, but my dad believed that other drugs were somehow worse. Other drugs were somehow what Black and brown people did, what poor people did, what people did who couldn't work, what people did who lived on the streets, what people who were homeless did. Drugs. Alcohol wasn't a drug. And when I first started running treatment centers, I realized right away that I had less judgment about the people who came in who were had primarily alcoholism versus people who came in who were using other drugs. And I had to really work at that to unwind that because it went really, really deep. So that's some of what I'm, part of the reason that I share that during this workshop is I really want to ask all of you, and maybe anybody who ends up listening to this afterwards, since the recording will be out there. I share that in the spirit of we can, at any age, at any time in our career, we can increase our self-awareness and start to notice. And I'm going to tell you some of the signs, like some of the signs and symptoms that we might have a bias and a judgment. And we can unwind them. We can purposely work on them consciously to counter them and often extinguish them. Often we have very difficult experiences at work that create these biases as well. I'm guessing that the people on this call right now have had difficult experiences in your practices, in your clinics around people who have addictive disorders or people who have chronic pain. And so sometimes we end up developing these ideas like that people who have chronic pain are really angry. Or if someone comes in and yells at one of our medical assistants, we say, oh, they must have addiction. So we start to, it's not really accurate that anger is not a symptom of addiction. So if someone's angry, they might have addiction, but they might not. It's not all by itself a symptom of addiction, but in our work world, difficult experiences at work might combine to create biases for us. This is one of the movie like pictures that I was talking about. This is like very, very popular movie in the late 80s that you can see how, Black and brown people are portrayed and also how people with addiction are portrayed. And of course, they're all gang members. And here's our white cops. So let me ask you another question. If anybody would like to text in your answer to this. I wanted to ask what you know about judgment and bias. What are judgment and bias related to? In the research, what do we know? Is it related to inaccurate diagnosis? Is it related to client complaints and grievances? Is it related to escalations? Patients withholding important health information? Yeah. So that was Lindsay. Yeah, all of these. And you might already know or suspect this, but there is really very solid research on every single one of these. When we as providers have judgment and bias, whether it's unconscious or conscious, it is related to inaccurate diagnoses. It's correlated. And the reason is the same example that I gave about the patients that I said I had biases about them having disability paperwork. When we have judgment and bias, we tend to lose our curiosity. So we stop asking people questions. We stop asking them for their story. We stop trying to understand. And so we don't get useful data. We don't get meaningful data from people, and we end up making inaccurate diagnoses. One of the things that I do is I do chart audits for stigma-related diagnoses and language. And often what I see in charts is people who have been diagnosed with an addictive disorder who have never been assessed for an addictive disorder. And they do not have any documented signs or symptoms of an addictive disorder. And so that's an example of how an inaccurate diagnosis can come from judgment and bias. Client complaints and grievances. Some of you probably know this. You may have worked very deeply in complaints and grievances. I've done a lot of quality improvement work on complaints and grievances, and I have seen what the literature says, which is 80% of client complaints and grievances are around patients feeling like they were treated disrespectfully. So I know sometimes we say, oh, it's the chronic pain patients or, people who are addicts and they didn't get what they wanted and so they complained. But when we drill down on the data, that's not actually accurate. What we see is it's people who feel like someone didn't listen to them, felt like they were dismissed or invalidated or treated disrespectfully. That is the most common complaint and grievance. I will say that it's also the main reason for litigation. So many of you might know that in the malpractice and litigation research, we see that it's not medical errors that drive litigation. It's patients feeling like they were treated disrespectfully around that medical error. There's some very compelling research where they tape patient-provider interactions and then they mute the words, but keep the tone. And researchers are able to predict with total accuracy which physicians will have more than one litigation suit against them in their career just by their tone of voice. And that is around, so when we have judgment and when we have bias, then we typically, our tone of voice changes. We don't make as much eye contact. We're shorter with people. We don't smile as much with them. And it's certainly related to escalations. When people feel judged, when they feel the bias, then they're more apt to escalate and get angry. And then, of course, when people feel judgment from us, they do not tell us important health information. People sort of suss us out as people who aren't really safe to share with, and so they don't. So, of course, judgment and bias, as you can see, has enormous impact on well-being. And part of the reason is it isn't just a thought. If it was that we just had the judgment and the bias in our minds and it really didn't come out, then maybe that would be one thing. We could say, well, that's just kind of what I think, but I'm able to hide that from my patients. But we typically aren't able to hide it from our patients. I'll tell you a little bit about how it leaks out in a minute. The person who wrote in that said they have suffered stigma and bias for anxiety and depression, it is still out there. There's no doubt. What I do want to say is a meta-analysis, when we look at stigma in society, and there's, of course, research on stigma, we do see that stigma for mental health conditions is decreasing. It's decreasing kind of slowly, but it is decreasing especially over the last 20 years, thanks to many of you, quite frankly, because the more that we treat mental health conditions in primary care, 80% of psychotropics are prescribed by primary care providers. It's really helped with the mental health stigma going down. Stigma for those with addictive disorders has been incredibly stubborn. It has not gone down, and it has continued to inch upward over the last 15 years. So when I said it would be one thing if we could keep the judgment or the bias to ourselves, but in my field, we call it leaking. When we have judgment, when we have biases, it leaks out. My son, who's 13, just said this to me the other day. I walked into his room and I immediately was like, oh my God, there's dishes in here. There's like wrappers in here. I had all kinds of judgments about it. And I said something else to him and he said, I know what you're thinking. Like, I know it's coming out in your tone of voice. And I just said to him, you're right. I just need to be totally straightforward with you because I cannot hide it. It comes out in our tone. It comes out in body language. It comes out in some of the ways that we scold, like saying things like, what did you expect? I had a patient who had COPD, who had been smoking a pack or two a day for many years. She was crying in my office because she'd just been diagnosed. And I asked her, tell me more about your tears. Tell me what's making you so sad. And she said, it's not the diagnosis. It's that the doctor, when I started crying, the doctor said to me, what did you expect? Of course, it's understandable, right? I'm sure I've said that to my kids at some point, or maybe I've even said it to a patient. That's driven by judgment and bias. That's the way it comes out. Often it makes us say the words should, you should do this, you need to do this, you must do this. Those are lack of autonomy words. And then often when we're in bias and judgment, like I said, we're less curious. And so we tend to ask less questions. Okay, what's this one? It's just like a pop quiz. Which chronic disease has the highest relapse rate? What do you think? Diabetes, asthma, addiction, hypertension? Anybody want to take a stab at it? One or two of them? You can probably feel the trick question in this. Anybody? Asthma and hypertension are way up there. Relapse, of course, means stopping self-management activities, and then the symptoms of the disease come back. So if we think about asthma and hypertension, people are more apt to stop self-management, stop the medications, stop the preventative, measures for asthma, and have symptoms return. Addiction's high. It's high. It's not the highest though. So it's just an example where some of our beliefs around the relapse rates of addiction being so much higher than other chronic diseases is more driven by stigma than it is reality. So I want to talk a little bit about countering biases. What can we do? We're human, we have them. So what can we do? Of course, the first thing is to help our unconscious biases become conscious. And part of the way that we do that is to make it okay to just say we're human. Of course, we have judgments and biases. If we say to ourselves, I don't have any biases, I'm a totally unjudgmental person, I'm a totally unbiased person, it pushes those biases deeper into our unconscious. We've just come off of, not to be too political, but we've just come off of an administration with someone who often said, I'm the least racist person. Sometimes you might interact with people who say, I don't have any, I'm the least sexist person that you'll ever meet. And so whenever we say we don't have any of that, it tends to push it unconscious. So one of the ways that we can make it conscious is just to say, yeah, of course we all have them. Right? And sort of invite them to come to our awareness. We can look for clues that we have judgment and biases. This is what happened to me with people with disability paperwork. So we can notice thoughts, stereotyping, like if we have stereotyping thoughts, if we feel in our minds that we're just dismissing people. I want to just say something very specifically about pregnant women who are using substances, who have opioid use disorder or other substance use disorders. Like I said, most of us have been conditioned to have some stigma around addiction, particularly around drugs other than alcohol and other than nicotine. And for most of us, there's an even heavier stigma around women who are pregnant or parenting. So I would say that intersection of pregnant or parenting women who are using substances, there tends to be incredibly high stigma and judgment. And I've worked really hard on my own just because I still see patients in a practice with my two closest friends who do a ton of physicians who do a ton of OB work. So a lot of the women that I see are women who are using substances during pregnancy. And I feel like I'm, always uncovering new layers of sort of stigma around this and trying to work my way around it so I can be helpful to these women. So often we'll see or hear our own thought process of she should care more about her kids, or she doesn't seem like she thinks this is a big deal, or she doesn't seem like she cares, or right. Those kinds of thoughts are clues that we may be in bias or judgment. If we find ourselves like less apt to connect, so not smiling as much at people, that's a clue that we might be in judgment and bias. If we have anxiety or fear around people, if we're easily irritated, lacking curiosity again, avoiding eye contact, if we're making fewer connecting statements. So sometimes we have patients that come in and we say, oh, it's so good to see you. I love your purse. How are your kids? And then sometimes other patients come in, we're like, so you're here for a follow-up, for your, so were you able to stop drinking? Did you go to AA? Sometimes we get like sort of straight to business. And so fewer connecting statements can sometimes be a way that we can notice that we might be in bias or judgment. The first thing that we can do is name it to tame it is like one of these things that comes from my field. It comes from the mental health field and I love it. And it just means that anything that we can label in our minds, it comes from cognitive behavioral therapy. Anything that we can label becomes less strong. So the first thing, once we notice judgment or bias, once we say, I've got some judgments about this, I can feel bias, then we can just name it. In our minds, we can say, yep, that's it. I'm stereotyping. I've got it. Yep, I've got some judgment. Just name it. We don't have to do anything with it in this moment. We just name it. It gives us a little bit of perspective on it. We call it perspective taking. It allows us to sort of sit back and look at our minds non-judgmentally. We can't really help judgment and bias by judging ourselves. Like judging ourselves for judging is not helpful. And so we're just naming it. These are what I mentioned at the beginning of this workshop, which is in their literature, in the research, they're called counter cues. I call them empathy hacks. They're ways that once we notice that we are having judgment, that we have bias around somebody who's in front of us, in the moment, we can wake our empathy up and get that teeter-totter back on the empathy side so we can be most effective with the person in front of us. So we learn these in graduate school as therapists. If we aren't able to empathize with our clients, we're not able to help them. We're actually bound by our ethical code to refer people out if we can't empathize with them because we're not able to influence them. Now we know that that's also true in medical care, that, when we're in judgment and bias, that patients don't get better. And so we want to be able to correct it as soon as we notice it. So imagining, we call this perspective taking, like just imagining what hardships the other person has experienced can wake up our empathy. So if I have someone who's right in my like stigma bias intersection, would be somebody who is kind of an angry, older white male, very much like my dad. Once they come in and they seem a little demanding or entitled, and I start feeling like this judgment and stigma, then what I immediately start thinking is like, gosh, I wonder how hard their lives are. I wonder what they've gone through. I wonder like what their housing is like. I wonder what their relationship with their family's like. We don't actually have to know what's true or not. We just start to imagine hardships. One of the quickest empathy hacks is often to imagine the person as a child. Our empathy is wide open for children. It tends to be like just really, really big and easy for kids. And so if we have someone in front of us that we don't have empathy with in that moment, we can imagine them as a child. Often when we're seeing women who are using substances, we sometimes our empathy is with the baby or with another child that they have. And what we can do to include them in our empathy is to also remember that they were a child as well. And this actually works with family members as well. So I have a brother that's he also has a substance use disorder that he's still active in, and he's difficult for me. And sometimes when I'm talking to him, or if he's in front of me, I can kind of move him back into childhood and wake my empathy up. But we don't have to have known people as children for this to work. There's many of these counter cues. And so if any of you have some that you reliably use, I'd love to hear them. Please feel free to chat them in. The other one is to identify commonalities. So if we have a woman in front of us who is using substances, we got a urinalysis back that shows positive for opioids or other substances. It might make us feel very different from her, right? We might have judgments about it that we're so different. And so one of the things we can do is remind ourselves what we have in common. We're both parents. We both have parents. We both want what's best for our kids. It's a way to sort of bring us back together as like a human talking to a human. And then, of course, very similar to the first one about wondering about what difficult experiences this person has, is considering that the person in front of you very likely has had trauma or adverse childhood experiences. We don't necessarily know that, and we don't have to know that. It doesn't have to be true. We can just reflect on the fact that people who struggle with substance use disorders, women who are pregnant who are struggling with substance use disorders, it's very common, very often, that they have had trauma or very difficult experiences in the past. And really reflecting on this in the moment when they're in front of us can often make that teeter-totter tilt this way, away from judgment and towards empathy. This is just universal empathy. If you have amazing receptionists and medical assistants, that's incredible, because they often show initial goodwill, kindness, and empathy to your patients. There's nothing that can replace a goodwill greeting, to say to someone, "Hi, I'm so glad you're here. I don't think I've met you before. My name's Elizabeth. What's your name?" There's just nothing that will replace that kind of greeting when someone walks in your clinic or hops on the video or picks up the phone with you. Open-ended questions, which are considered the gold standard of communication. That's the Institute of Medicine that said that. It shows that we really want to listen to people and we really want to hear what they say. And affirming strengths. The women that I work with who are using substances while they're pregnant, I invariably say to them, I always think to myself, what can I reflect back to them that I see what is good about them? I don't just see a problem. And I almost always say, yes, please, questions in the chat. I almost always say, thank you so much for coming to see me. I can imagine you were probably hesitant to come see a therapist when the doctor told you that they wanted you to see somebody because you're using substances, and you could have not come and you did. And that's amazing. And thank you. And I often say to them, I know you really, really care about your baby's health. I can hear that. And when someone's using substances, like they're often afraid that we're going to think that they don't care about their babies. So affirming strengths is a way to share back with them that we see what is good about them. Let me just pause for a minute and just ask if people have questions, things that they would add, things that they use to get from judgment into empathy. I would love to hear. I'm going to just talk through these three things, but please don't hesitate. I'd love to hear from people. Presence, acceptance, and appreciation are, if we think about that teeter-totter and moving that stigma and judgment down and moving the empathy part up, those three things that I had on this previous slide they're evidence-based ways to communicate empathy. So once we've kind of mitigated that judgment, how do we jump into showing empathy? So these three ways are evidence-based. I think that these words, I feel like, sort of get to this deeper, almost probably somewhat spiritual connection. And it gets to probably the deepest reason that we chose to come into the helping professions, is that even if the person in front of us is not ready or able to stop using, or may not be ready or able to begin treatment, no matter where they are in their use of substances, we can help just by being present, just by trying to clear our mind for a moment, just by sitting with somebody, by showing them acceptance, mitigating those judgments, and really, really working to feel acceptance in our hearts that people do the best they can. And this may be the best this person can do. And appreciation about saying out loud to people, thank you for coming in to see me today. Thank you for being willing to share this with me. Thank you for having this conversation with me. And I know that you care very much about your baby. I used to do workshops for the March of Dimes, and the March of Dimes has like sort of their own canon of research. But one of the things that we talk about all the time when I was doing March of Dimes work is that when we're in judgment and bias, we often think to ourselves that women who are using during pregnancy don't care about the health of their baby. And what we find in sort of, there's sort of solid research about this, but I think even spiritually, most of us probably know this, that there's just a tiny, tiny, tiny fraction of a percentage of people who don't seem to have the care about their baby's health. And that is obviously someone who's fairly damaged. But upwards of 97% of women, no matter what they're doing or what they're using, have a deep, deep care about their child and their child's health. So being able to share back with women that we see this and that we know that is a really, really powerful way to convey empathy. And sort of looping back to the very beginning of where I started, empathy is the opposite of stigma, and empathy all by itself is a treatment. So I just want to say before we end that SSVMS has this incredibly beautiful flyer. It is patient facing, so it is for your practices. It's a vector image, so it can be made into posters. It's free if you would like this for your organization to speak to your patients about treatment that is available to them. If they have opioid use disorders, then you can email Marley, who is Lindsay's team, and she can get you these. And then the last thing that I'll say is that I wanted to give you my website. There's a lot of resources on there. Everything's free, so this is not a sales pitch. I have a lot of resources around stigma and motivational interviewing and addictive disorders. And there's also bibliographies on there that have, sort of exhaustive research about some of the things I've talked about today. And with that, I'll stop.
Wonderful. Thank you so much, Elizabeth. We're actually out of time. So wonderful. So just a reminder to everybody that is logged in this evening, you will receive a email later this week with a survey link to fill out your evaluation for the CME. And then after that, you'll receive your CME credit. And Elizabeth, thank you. I personally learned a lot. I don't see patients and I still got something out of this. So I appreciate you and thank you again. And good night, everybody.
Have a great night, everybody. Thank you for being here.